Welcome dear students. In continuation to our previous class, we are learning about the disorders of external auditory canal, and there are 5 types. First is congenital, second is inflammatory, third is neoplastic, and finally a few miscellaneous conditions. So we have already learnt about congenital anomalies, and in this class let us learn about the inflammatory conditions of external auditory canal. So they are all broadly together called as otitis externa, and that is our topic for today. Let us learn about the different types of otitis externa. Broadly, they are of 2 types. First is infective etiology, and the second group is reactive. And the terms are self-explanatory. Infective disorders, further we can list them under first bacterial. Under bacterial we have localized otitis externa, diffuse otitis externa, and finally malignant otitis externa. After bacterial group, next comes viral, and finally of course fungal. These are the sub-varieties under infective category, and let us learn all of them one by one. First is localized otitis externa, and this localized otitis externa is also called as furunculosis, furuncle. What is a furuncle? Furuncle is a bacterial infection of the hair follicle in the external auditory canal. A small recap from the anatomy of external auditory canal. Hair follicles are present only in the outer 1/3, the cartilaginous part of external auditory canal. So furuncles are possible only in the outer 1/3 of external auditory canal. So what is a furuncle? It is a bacterial infection. What is furuncle? It is a bacterial infection caused by inflammation of the hair follicles. It is caused by inflammation of hair follicle in the external auditory canal, of course, because we are learning about otitis externa. Localized otitis externa is nothing but a furuncle, which is bacterial infection of the hair follicle, and hair follicles are present only in the outer 1/3. Next common point, what is the etiology? Most common organism is Staphylococcus aureus, the most notorious bacteria responsible for most infections and a very resistant one. That is, Staphylococcus aureus is the most common cause of otitis externa, and the furuncle could be single or multiple furuncles are also possible. In this furuncle, the infection may spread to the surrounding structures also, and it can cause abscess or cellulitis. The infection spreads and it can cause abscess or cellulitis. And I have a picture here. This is how a furuncle looks like. As you can see, this is an image of the furuncle. So how does this infection occur? The way it begins is because of constant scratching, the external auditory canal undergoes some abrasions. The skin undergoes abrasions and raw areas are formed, and that predisposes to infections, and Staph aureus is one of the most common organism. Or any other trauma to the external auditory canal can also predispose for infections. Any use of any contaminated objects such as contaminated hearing devices, stethoscope or any ear molds, anything that is put into the ear, if it is contaminated, it can of course lead to infection. Now let us learn about the clinical features of a case of furunculosis. So when there is infection, obviously the patient will have pain. Ear pain is called otalgia. Tenderness. Pain and tenderness are present, and this pain gets aggravated upon pulling the auricle. When the patient is already having a furuncle inside, any movement of the auricle, even when you are trying to pull the auricle and examine, that causes a lot of pain. The pain gets aggravated. And depending upon the position of the furuncle, it can cause some other special symptoms. See, the external auditory canal is a canal. It's a cylindrical tube-like structure. So, if the furuncle is present on the posterior meatal wall, we have already studied about the relationships of external auditory canal. Anteriorly, it has temporomandibular joint. Posteriorly, it has the mastoid. Inferiorly, there is the parotid gland, and superiorly, it is the base of the skull. So, depending upon where this furuncle is present, it can cause some specific symptoms. If the furuncle is present anteriorly, the chewing movements become difficult, because for that, the temporomandibular joint has to move. Chewing becomes painful. If the furuncle is situated on the posterior meatal wall, towards the mastoid, then that can cause edema over the mastoid region. Edema over mastoid region. And when there is edema and swelling, the retroauricular groove or the retroauricular sulcus will sometimes get obliterated. When there is severe swelling, the retroauricular groove gets obliterated. Because of the edema and swelling. Now this is a picture showing the same. In this case, the furuncle is present on the posterior meatal wall, and as you can see, there is swelling on the mastoid area, and even the retroauricular groove is somewhat obliterated. Not completely, but somewhat obliterated. If the swelling increases, it becomes totally obliterated. And in such cases, even the pinna could be displaced depending upon the severity. Obviously, a swelling behind will push the pinna. It is displaced forwards. Next, any infection, another common thing that we see is the lymph nodes get enlarged and swollen, and they are also tender. So what are the lymph nodes present in this area? Periauricular lymph nodes, and there are three groups: anterior, posterior and inferior periauricular lymph nodes. So even they are enlarged and tender. Periauricular lymph nodes are enlarged and tender. Yes, and this furuncle might rupture at some point, and if at all it ruptures, all the discharge comes out, and that will lead to purulent discharge. So these are the clinical features of furuncle. What are the differential diagnoses? Conditions resembling furunculosis. One is diffuse otitis externa, maybe it is not local, and there is diffuse otitis externa because the symptoms are more or less similar for diffuse otitis externa also. Second, it could be a case of acute mastoiditis because there is swelling over the mastoid. It is not necessarily a furuncle on the posterior meatal wall. It could also be acute mastoiditis. It can also be subperiosteal mastoid abscess. These are the three differential diagnoses that are possible. Next is, how do we treat this condition? Fine, we have diagnosed, and after considering the differential diagnosis also, we have come to a conclusion that it is a case of furuncle. Now, how to treat it? Because it is an infective condition, it has to be treated with antibiotics. Topical antibiotic creams can be applied and also systemic antibiotics can be taken. First and most important is antibiotics. And the patient is in a lot of pain, so definitely we have to give analgesics. And also some hot pack or hot fermentation can be applied over the auricle. That will also provide pain relief. Apart from this, a 10% ichthymol glycerine solution can be used, should be used rather. Why do we need to use this? Glycerine has hygroscopic action, that is, it absorbs water, and this will reduce the edema, reduce the swelling, and ichthymol has mild antiseptic action. So when you put this 10% ichthymol glycerine in the ear, it will reduce the edema and swelling, and it will also keep the ear in its shape. It provides support to the structure of the ear. It provides splintage to the ear. If at all an abscess has already occurred, for an abscess we need to do incision and drainage. That is the treatment for an abscess. Now, in case a patient is having recurrent furunculosis, why would somebody have recurrent furunculosis? In immunosuppressed or immunocompromised conditions. So, we need to evaluate the patient for diabetes. Is diabetes the cause for recurrent furunculosis? It has to be investigated. And then you need to counsel the patient, it is very important, about two things. One is, he is supposed to maintain ear hygiene by not putting contaminated objects into the ear. He must avoid scratching, putting hairpins, Q-tips, earbuds, cotton swabs, whatnot, anything. All those practices have to be avoided because they are a source of infection and they also cause abrasions, traumatic lesions in the external auditory canal that will further predispose to infections. And second important thing that you need to advise the patient is, the nasal vestibule harbors Staphylococcus aureus bacteria, and if at all the patient has habits of nose picking and again putting the same contaminated finger into the ear, that is a common source of how the infection occurs from the nose to the ear. So the patient has to be advised about that also. These are the two important advices that you need to give to the patient, and they are also preventive measures. So this is all about furunculosis or localized otitis externa. And now let us study about a quick recap rather. It is a bacterial infection caused by inflammation of hair follicle and it is caused by Staphylococcus aureus, and there is pain, tenderness, chewing movements are painful, or there could be mastoid swelling in the mastoid area, and periauricular lymph nodes are also swollen. You treat it by antibiotics, analgesics, 10% ichthymol glycerine, and finally some preventive measures. Next, let us study about diffuse otitis externa. This is an important condition. It is the second condition in bacterial etiology. First was localized otitis externa and now it is diffuse otitis externa. The name itself is suggesting it is not local. The infection has occurred all through the external auditory canal. And this has some synonyms also. Diffuse otitis externa is also known as tropical ear, also known as swimmer's ear, also known as telephonist ear. All of them mean the same, diffuse otitis externa. So what is diffuse otitis externa? It is the diffuse inflammation of the meatal skin, and that can sometimes also spread to the pinna and to the tympanic membrane, epidermal layer, the first layer of tympanic membrane. That is diffuse otitis externa. Let me write it down for you. Diffuse inflammation of meatal skin. It can spread to the pinna and to the tympanic membrane. And what is the most common cause for this? Acute bacterial infection again. So, coming to the etiology. This diffuse otitis externa is common in hot and humid climates. 1. And it is also common in swimmers. And that's why it's called swimmer's ear. Now, what is the relation between climate and swimmers and otitis externa? Let us logically try to understand. In hot and humid climate, in summers, there is a lot of sweating. And this excessive sweating inside the external auditory canal will change the pH of that area. Normally, it is acidic because of all the ceruminous gland secretion and other secretions there. And this excessive sweating will change the pH from acidic to alkaline, and this alkalinity will predispose to infections. That is the logic behind hot and humid climates predisposing to diffuse otitis externa, and the same happens with swimmers also. The pH gets changed and that will lead to infections. Second, as always, infection is introduced because of contamination. Use of contaminated things into the ear, introducing contaminated things into the ear. So actually, I can broadly divide how that contamination occurs. It is because of trauma. Any trauma that occurs to the ear, that is responsible. Contamination, trauma go hand in hand. And that will further lead to invasion by pathogenic organisms. So, trauma to the external auditory canal can occur because the patient himself introduces various substances to scratch the ear. Scratching of ear is done by the patient by Q-tips, some sharp instruments like pins, cotton swabs, cotton buds. They also actually use matchsticks. All these things the patient is introducing. Another possibility is unskilled instrumentation by the doctor. This can happen when the doctor is trying to remove a foreign body, or while performing an oral toilet. During these procedures, they introduce instruments, and if the doctor is not skilled enough, he can cause microabrasions in the skin of the external auditory canal. So these things by the patient or by the doctor will finally cause microabrasions, raw areas, and these raw areas will predispose to infections. In case of the patient, these substances themselves, Q-tips, pins and all, they themselves can contain infection, so they can become source of infection, plus the microabrasions they cause will also predispose to the patient to infections. This is the entire reason behind it, and this etiology keeps repeating everywhere, and that is why I have written it in detail. It is the etiology for furunculosis, it is the etiology for diffuse otitis externa, and so many other conditions that are about to come. So please understand this properly, because it's going to be repeated again and again. Microabrasions, they will cause a breach in the lining of the skin, and that will predispose for the invasion of pathogenic organisms. Now the most common organism is Pseudomonas. Pseudomonas aeruginosa is responsible for almost 38% of the cases. It is the most common organism for diffuse otitis externa. Next, this is followed by Staph epidermidis, and finally by Staph aureus. But please remember, Pseudomonas is the most important organism. And we are learning this under bacterial infections, but please understand that fungal infections can also cause otitis externa. Of course, we would learn them under otomycosis, but even they can cause diffuse otitis externa. Usually after a bacterial infection, it can be followed by a fungal infection by either Aspergillus niger or Candida albicans, anything like that. They're more common in immunosuppressed individuals. So now what are the clinical features of diffuse otitis externa? Again, the patient would of course have pain. The patient will also have itching, pruritus, tenderness will be there. There will be discharge also. In furunculosis, discharge occurs only if the furuncle ruptures, but in diffuse otitis externa, usually discharge is present. And because of all this, there could be conductive hearing loss. Conductive type of hearing loss. It's a temporary reversible type of hearing loss. Okay. So we can divide the course of diffuse otitis externa into two phases. That is acute phase and chronic phase. Let us see what's happening. Acute phase is when the disease lasts for less than 6 weeks, and if it is for approximately 6 weeks to 3 months duration, we say it is chronic otitis externa. So in acute phase, initially the patient will have pain, all the features that we have spoken above. Pain will be there, and that is aggravated by jaw movements. Okay, and then there is discharge. That's usually a serous type of discharge. Then that is followed, the serous discharge is followed by a purulent discharge, and the lining is all swollen and inflamed. These are the features seen in acute phase. Okay, let me quickly write it down for you. There is pain, and that pain is aggravated by jaw movements. And then there is serous type of discharge followed by purulent discharge. Okay, and all these secretions, they are present all over the external auditory canal, but I told you there is one special area where generally the secretions get pulled up. And what is that? that is the antero-inferior recess that is present behind the isthmus, that is present medial to the isthmus. That's a recess-like area where all these collections and debris gets accumulated. So they are all pooled up in antero-inferior recess. All the secretions are pooled up there. All the debris is also pooled up there, and of course the lymph nodes are enlarged, and even cellulitis of the surrounding tissues is seen. That is why I said in the differential diagnosis of furunculosis we have to also consider diffuse otitis externa, because the clinical features are more or less same, except that furunculosis is just one hair follicle that is inflamed that you can see, and diffuse otitis externa is more or less diffuse. Next, that is the reason why otoscopy, examination of the ear, is very important to make the diagnosis. With that you can differentiate what is a furuncle, what is diffuse otitis externa, what is otitis media, and everything else. Next, the spectrum of the disease, it can be anywhere from a mild disease to a very severe type, depending upon the presenting features and the physical examination. We can divide that. Mild disease, the patient will just have some minor discomfort and pain in the ear, and the edema is also moderate. But in case of a severe disease, the pain is very severe. It is disproportionate to what you see. So in severe cases, there is lot of pain and pruritus, itching, and because of the high amount of swelling, the external auditory canal can also get occluded. After examination of the ear, the next thing is we need to assess the severity of the condition. It could be a mild disease where there is just ear pain by the patient. The patient experiences a mild amount of pain and some discomfort and very little discharge. And this is how it looks. You can see in the first picture, the external auditory canal shows some wavy pattern. All this that you are seeing here, ups and downs, these are actually the swellings. This is because it is swollen. This is a mild form of the disease, and the discharge is also mild, less in quantity, I mean to say. And in the next stage, if it is moderate kind of disease, you can see it is almost filled with discharge, and because of the swelling, even the canal becomes narrow. And in severe form of disease, the external auditory canal, the skin lining it, becomes totally edematous, making the canal very narrow. So these are the three phases, and of course in severe phase, the pain is also excruciating. Okay, and then these are the three, it is the grading of severity of diffuse otitis externa, and the lymph nodes are enlarged. This is about the acute phase. In case of chronic phase, as I said, it lasts anywhere between 6 weeks to 3 months. And what is exactly happening in the chronic phases? The patient has an intense desire to scratch. There is recurrent irritation. And also an intense desire to scratch. And because of this, what happens, the moment it is healing, again the patient would scratch, introduce infection or make it raw and predispose to infections, and again the cycle continues, and whenever there is an infection again, that will lead to acute exacerbations of the disease. It is always swollen, and in between there are acute exacerbations where there is an increase in pain and also there is discharge. But the discharge in chronic phases, it is scanty. In acute phase, it is initially serous and then purulent, but in chronic phase, the discharge is scanty. And even this discharge dries up to form crusts. It dries up and it forms crusts. And then the meatal skin, because it is constantly edematous and constantly swollen, that will also show some fissures and scales. Meatal skin shows scaling and fissuring. And finally, there occurs a stage, very rarely, where the skin becomes permanently hypertrophied and it will lead to meatal stenosis. Because of the constant swelling, the skin becomes permanently hypertrophied and it will lead to meatal stenosis. We call it chronic stenotic otitis externa. It has a special name called chronic stenotic otitis externa. That is the final condition. Now let us learn about the treatment of this condition. So first, in acute phase, the most important thing that has to be done is oral toileting. That is cleaning of the external auditory canal. All the cerumen, the secretions, debris, slough, everything has to be cleaned up, and it has to be gently and meticulously cleaned. It has to be done gently, because again, if we do it harshly, it can cause further trauma and infection. And it has to be done meticulously in the sense, the antero-inferior recess, which is slightly hard to access because it is beyond the isthmus, but that is the area where all the secretions get pulled up. So that area also has to be specially cleaned during oral toileting. And then all the exudate has to be removed, and that discharge that gets accumulated after it is cleaned, the next step that we do is we take a gauze piece, a wick that is soaked in antibiotic solution, and put that there. A gauze wick. Soaked in antibiotic solution is placed in the external auditory canal. That is the next thing that we do, and also we can add some local steroid drops. Why do we need to put steroid drops? To reduce the inflammation and swelling, because the external auditory canal is becoming narrow and narrow because of the swelling, and for that we can put some local steroid drops. That will also prevent itching. Itching and erythema can be prevented and controlled by using steroid drops. We can use hydrocortisone or dexamethasone. And then we also put aluminium acetate or silver nitrate solutions. These are mild astringents and they can be used to protect any coagulum formation, because coagulum will again cause an increase in the infection. Aluminium acetate or silver nitrate drops can be used. Okay, and of course topical antibiotics are important. Topical antibiotic drops, they are the main thing that are going to control the infection. We have to use combinations, generally a combination of fluoroquinolones with aminoglycosides is used. Because Pseudomonas is a resistant organism. And in case, even after antibiotic treatment, broad spectrum antibiotic treatment, if the infection is not getting controlled, we can send the discharge for culture and sensitivity, and based on those reports, antibiotics can be decided. And in case the external auditory canal is very swollen and it is not allowing any local treatment, then systemic antibiotics can also be used. In case local treatment is not possible because of the intense edema, then systemic antibiotics can also be used. And after it subsides, then we can shift to topical antibiotics again. And finally, analgesics can be given for pain relief. This is the treatment of acute phase. What should be done in chronic phase? For some reason, the patient has progressed into chronic phase. In this condition, what we do is, we try to again reduce the swelling, that is most important here, by inserting a wick, a gauze wick that is soaked in 10% ecthamol glycerin. As I already told you, ecthamol is hygroscopic, so it reduces edema. This is done, and in case the patient is in an acute exacerbation, again we can do ear toileting. And topical antibiotics with a steroid cream can be used, and that will help in itching. Itching is the main problem here. So steroid cream is important. A topical antibiotic plus steroid cream can be used in combination to reduce itching. And in case the patient has already gone into chronic stenotic otitis externa, that is, the meatus is so narrowed that it does not allow any meatal treatment, it does not allow any local treatment, and that is also causing hearing loss, then we have to go for surgical excision. Then we have to go for surgical reconstruction of the canal. That is canaloplasty, wherein the bony meatus is widened. Now please remember, the surgical treatment is only for chronic stenotic otitis externa. Now this is how we treat the conditions, but in spite of our best efforts, sometimes complications do occur. And now let us study about the complications that can occur in diffuse otitis externa. One is cellulitis can occur. Perichondritis can occur, that is inflammation of the cartilage. As we initially studied, this infection can spread to the auricle and it can also spread to the tympanic membrane. So when it comes to the auricle, even the outer 1/3 of external auditory canal is made up of cartilage, and auricle is also largely made up of cartilage, and they can get inflamed and cause perichondritis. Another thing, it can cause fibrosis of the canal. And finally, the next condition, it can cause malignant otitis externa. Now, if you remember, under bacterial otitis externa, we have listed out three things. First was localized, that is furuncle. Second is diffuse otitis externa, and third is malignant otitis externa, which occurs actually as a complication of diffuse otitis externa. So this is all about diffuse otitis externa. It has an acute phase and a chronic phase, and you have to treat each of them. And these are the complications: cellulitis, perichondritis, it can cause fibrosis of the canal, and finally it can also lead to malignant otitis externa, and that is our next topic. So the next condition is malignant otitis externa. Malignant otitis externa is also called necrotizing otitis externa. Malignant in the sense, a very severe form of the disease. It's not a neoplastic condition, it's an inflammatory condition only. Just to indicate the severity of the disease, the word malignant has been used. So what is malignant otitis externa? It is also inflammation of external auditory canal only, but it is caused mostly by Pseudomonas in immunosuppressed individuals, immunocompromised individuals. As such, Pseudomonas is a notorious bacteria, and when it occurs in immunocompromised individuals, who are immunocompromised individuals? The ones suffering from diabetes, from HIV/AIDS, from who are on steroids, who are on immunosuppressive drugs, post-transplant patients. All of them are fall under immunocompromised category, and if they happen to get infected by Pseudomonas, that will lead to malignant otitis externa, and they will have excruciating pain. Normally also otitis externa is painful, but here it is very severe, excruciating pain. And another feature that you see is appearance of granulations in the external auditory canal. So when you see granulations, it means that it could be malignant otitis externa. And this infection can spread to the base of the skull, it can go into the jugular foramen, and it causes multiple cranial nerve palsies. It can spread into base of the skull, jugular foramen, and finally cause multiple cranial nerve palsies. Now, how do we diagnose this condition? First, based on your clinical suspicion, if at all you know that the patient is diabetic or is a recognized, is a known case of immunosuppression, then when you see that he is having otitis externa, you have to suspect it could be malignant otitis externa. But we also have to investigate First is a strong clinical suspicion, and then we perform a CT scan. A CT can detect, but a gallium-67 scan is very sensitive, and it can also be used for follow-up. Follow-up in the sense after treatment, if at all the patient is improving or not, can also be detected by this gallium-67 scan, because gallium-67 takes up monocytes and reticuloendothelial cells, the inflammatory cells that are present in that area, and if our treatment is working out, if the treatment is successful, then automatically the cells would come down and the gallium scan would show those results. So it's used for both diagnosis and follow-up, and you can repeat the gallium scan every 3 weeks to assess the progress of the patient. And another thing, there's another scan called technetium-99 scan. This technetium-99 is even more sensitive and specific than gallium infection, and it can also reveal bone infection. But the problem with technetium-99 is that it cannot be used for follow-up. It remains positive even after 1 year. Even after we give the treatment, technetium-99 remains positive, so it cannot be used for follow-up. Gallium can be used for follow-up. Technetium-99, although it is more sensitive and specific, it can't be used for follow-up. So we do these investigations, and finally we have understood it is malignant otitis externa. Now, how do we treat this condition? Now, the disease has mainly occurred because of the immunocompromised nature of the patient, and so we have to address that very importantly. So mostly it occurs in diabetics, so treat and control sugar levels, control diabetes. That is the first thing that we have to do. And just like any other otitis externa, we are supposed to do ear toileting, clean up all the secretions, and also use antibiotics. Again, this is also by Pseudomonas, so we have to use antibiotics in combination, fluoroquinolone plus aminoglycoside, or we can also use third generation cephalosporins. Third generation cephalosporins with an aminoglycoside. Or fluoroquinolones plus aminoglycosides. In very severe cases, we can also give them IV. Quinolones can be given oral. Third generation cephalosporins are usually given IV. And if at all the patient doesn't respond, we send the discharge to culture and sensitivity and then decide the antibiotics based on the report of culture and sensitivity if the patient doesn't respond. So this is about malignant otitis externa, which is actually a complicated condition. It can occur as a complication of diffuse otitis externa, but it's usually seen in immunocompromised individuals. So with this, we complete all the bacterial infections. Let me quickly recap them and summarize. So under infective heading, we have bacterial. In bacterial, we have three varieties again: localized, diffuse and malignant. Localized is called as furunculosis, and a furuncle is a bacterial infection caused by inflammation of hair follicle. And most commonly it is because of Staphylococcus aureus. It is Staph aureus, that's a question. And clinical features are pain and tenderness, and if the furuncle is anterior, it can cause pain during chewing, and if it is posterior, it will cause edema over the mastoid region, and retroauricular groove can be obliterated. This is what you can see in this picture here, and the pinna can be displaced forwards in severe conditions. And periauricular lymph nodes are enlarged and tender. And these are the three differential diagnoses: diffuse otitis externa, acute mastoiditis, and subperiosteal mastoid abscess are the possibilities. And how do we treat it? Antibiotics, analgesics, and hot pack. 10% ichthymol glycerine is important. 10% ichthymol glycerine. Why? Because glycerine is hygroscopic. It absorbs water, and so it will reduce the edema, and ichthymol is mildly antiseptic, and hence we use this. If at all an abscess has already formed, then we have to do incision and drainage. And if the patient is suffering from furunculosis recurrently, then evaluate the patient for diabetes, and finally counsel the patient about ear hygiene, how he has to not put contaminated objects into the ear, and how he is not supposed to pick the ear and put the same finger into pick the nose and put the same finger into the ear. And next is diffuse otitis externa, also called as tropical ear or swimmer's ear or telephonist ear. And this occurs, this is due to diffuse inflammation of the meatal skin. And etiology is hot and humid climates, and swimmers are usually predisposed to this condition. It occurs because of contamination. Trauma can occur. Patient has this habit of scratching the ear with all these substances, and it can also occur because of unskilled instrumentation by the doctor, or going to treatment with to some coax can also result in this. Generally, during procedures like foreign body removal, the external auditory canal can be damaged. It undergoes microabrasions, and that will predispose to infections. Most common organism is Pseudomonas, followed by Staph epidermidis and Staph aureus. Clinical features: the patient will have pain and pruritus. Pain will be there, pruritus is there, tenderness and discharge is also there, and the patient can also have conductive type of hearing loss that is reversible and temporary, and it is also a mild type of conductive hearing loss. And it is of it can be divided into two phases: acute and chronic. Acute is if it is less than 6 weeks, there is pain, and that pain is aggravated by jaw movements, and the patient has a serous discharge followed by purulent discharge, and this discharge and all the debris gets collected in the antero-inferior recess. So these are the three stages, three types of severity. The first one is a mild variety, and this is moderate variety, and this is finally severe variety where the canal is very badly swollen and it is very narrow. And in the chronic, and how do we treat acute phase? Oral toilet is most important. The single most important thing that we have to do is oral toilet. It can be a question. Next, after cleaning the external auditory canal, we can take a gauze wick that has been soaked in antibiotic solution and place it inside the external auditory canal. Local steroid drops have to be used. Aluminum acetate or silver nitrate can also be used. And then topical antibiotic drops and analgesics. If it is chronic phase, if the patient has entered the chronic phase, which is anywhere between 6 weeks to 3 months, then the main problem is there is recurrent irritation and an intense desire to scratch. So to address this, we need to, there are acute exacerbations in between because the patient is scratching, and the discharge here is scanty and it can also dry up to form crusts, and the meatal skin shows fissuring and scaling. And finally, in severe cases, very severe cases, because of constant swelling, the skin is hypertrophied and it will permanently narrow down the external auditory canal, and we call that chronic stenotic otitis externa. So as I said, there are acute exacerbations, and to treat that we can use a gauze wick soaked in 10% ecthymol glycerine and also do ear toileting. And because the patient has an intense desire to scratch, we give topical antibiotic with a steroid in it, so that the steroid will reduce the desire to scratch, because itching comes down with steroid cream. And finally, if at all the patient goes into chronic stenotic otitis externa, then we need to do a surgical correction. Canaloplasty has to be done where the bony meatus is widened. And the complications of this condition are cellulitis, perichondritis, fibrosis, and finally malignant otitis externa. Now let us learn about revise malignant otitis externa. The most common organism is Pseudomonas, which causes malignant otitis externa, and it occurs in immunocompromised patient. So if in a clinical scenario, if immunocompromised patient is given in the question, please think about malignant otitis externa and Pseudomonas. The patient will have excruciating pain, and another hint that you will get in the question is that there are granulations in the external auditory canal. And this infection can spread to the base of the skull and jugular foramen, making it very dangerous because it can later on cause cranial nerve palsies. Diagnosis is by our high level of clinical suspicion, and then we can do a CT scan and gallium-67 scan that can be used for both diagnosis and follow-up, and technetium-99 scan is also very good for diagnosis, but it cannot be used for follow-up. How do we treat the condition? Because it is mostly because of the immunosuppressed condition of the patient. First, try to get the patient out of that immunosuppression or out of that immunocompromised state. If at all it is diabetes, treat and control diabetes, and then do ear toileting and give antibiotics that are directed against Pseudomonas. And sometimes it is not Pseudomonas and some other organism is possible. So for that, do a culture and sensitivity, and based on those reports, decide your antibiotics. But generally, we use a third generation cephalosporin with an aminoglycoside or a fluoroquinolone with an aminoglycoside. This is all about bacterial variety of otitis externa. Thank you very much.